In this presentation, we'll be learning about two disorders, heart failure and circulatory shock. Now, when a patient hears the diagnosis heart failure, they often assume it to mean their heart isn't beating, but actually, heart failure is referring to the failure of the heart to pump enough blood to meet the metabolic needs of the body. It can be due to inadequate ventricular filling or inadequate ventricular ejection. The big problem with this inadequacy is the metabolic needs of the body cannot be met. Now, you've already learned about different causes of heart failure. With coronary artery disease and myocardial infarction, the decreased oxygen and ischemia affect the heart's ability to pump. With cardiomyopathy, the heart muscle doesn't pump adequately. And with valvular heart disease, that causes impaired filling or ejection. Now, heart failure is classified as either reduced ejection fraction or preserved ejection fraction. But before we can talk about ejection fraction and whether it's reduced or preserved in heart failure, let's look at some important hemodynamic terms. As a reminder, the cardiac cycle consists of diastole, which is ventricular filling, and the normal amount of blood at the end of ventricular filling is 110 milliliters, which is about 4 ounces or a half a cup. Systole is ventricular ejection, and the normal amount of blood ejected with each heartbeat is about 70 milliliters or 2.5 ounces. That's around a quarter of a cup. This is called stroke volume, the amount of blood ejected with each heartbeat. Now, the fraction of the volume ejected at the end of diastole is called ejection fraction. To calculate this, you would take stroke volume divided by end diastolic volume. And the example on your slide is 70 milliliters divided by 110. So the ventricle is ejecting about 64% of the blood that is in there. A normal ejection fraction ranges between 55 and 70. So if you think about the ventricle ejecting, it's pushing blood up. It's never going to be 100% because that would just cause the ventricle to totally collapse. So sometimes patients will think, 65%, there's something wrong with me. But actually, 55 to 70% is a normal ejection fraction. Now, other terms you should know include preload, which is the volume of blood that stretches the ventricle at the very end of diastole. It's actually also called the end diastolic volume. So those terms can be used interchangeably. Afterload, which is the force that the contracting heart muscle must generate to eject blood from the filled ventricles. Afterload has two main components: peripheral or systemic vascular resistance, and that's the pressure caused by the systemic circulation. So in cases of hypertension, there's going to be an increased vascular resistance, which increases intraventricular pressure to open that aortic valve and eject blood. And this increased pressure equates to an increase in ventricular wall tension, which is the second component of afterload. In heart failure, cardiac reserve is maintained due to several compensatory mechanisms. The first I want to mention is the Frank-Starling mechanism. In this compensatory mechanism, the heart increases its stroke volume through an increase in the end diastolic volume, or preload. The myocardial fibers stretch, which increase the force of contraction. While initially this is helpful to maintain cardiac output, it increases left ventricular end diastolic pressure, which causes pulmonary congestion because the blood backs up. Also, the increased wall tension increases myocardial oxygen consumption, which isn't good. The second mechanism is the sympathetic nervous system, and that occurs in response to decreased cardiac output. So heart rate and contractility, vascular tone regulation, renal sodium and water retention all increase. Now initially this is helpful, but quickly it becomes maladaptive and results in deteriorating heart function. Increased heart rate and contractility increases myocardial oxygen consumption, and retention of renal sodium and water, as you know, increases fluid and increases the amount of blood volume that needs to circulate, and that is not good for a failing heart. Now, the renin-angiotensin-aldosterone mechanism we've already talked about with hypertension, and it is activated in heart failure. As a reminder, here are the steps. When there is decreased cardiac output, that results in decreased renal blood flow and glomerular filtration rate. That results in increased renin secretion, which causes angiotensin 1 to be secreted, which leads to angiotensin 2, which increases vascular tone, some vasoconstriction. That causes the adrenal glands to secrete aldosterone, which I know you remember results in sodium and water retention. These are all problematic in heart failure due to requiring an increased workload. Fourth, I want to mention myocardial hypertrophy and remodeling. The myocardial cells hypertrophy and remodel to compensate for the increased workload. Initially, that may be okay, but it changes the structure and the function of the heart, leading to pump dysfunction and hemodynamic overload. And last, but not shown on the diagram, are natriuretic peptides. These are produced and secreted by the heart muscle. They have a potent diuretic and natriuretic, which means, urinary elimination of sodium, vascular smooth muscle actions that affect cardiovascular function. These can be measured in the blood and are used to diagnose the severity of heart failure. Now, as I mentioned earlier, heart failure can be classified two ways. First, what is the effect on the ejection fraction? Is it reduced or is it preserved? And secondly, which ventricle is failing? Is it the left side or the right side? First, let's look at ejection fraction. Now, let's remind ourselves what ejection fraction is. Ejection fraction is the fraction of blood ejected from the ventricle with each heartbeat. And it's the stroke volume divided by the end diastolic volume. Normal is 55 to 70%. So in heart failure, patients can have a reduced ejection fraction or a preserved ejection fraction. The main question to ask is the heart failing to pump out enough blood or failing to accept enough blood from the body lungs. In the reduced ejection fraction heart failure, the ventricle cannot eject an adequate amount or an adequate cardiac output. The ejection fraction is less than 40%. There is an increase in end-systolic and diastolic volume, preload increases, but on the left side, most common, as the blood backs up, it accumulates in the lung, causing pulmonary congestion. And we'll look at these manifestations closer on the next slide. In preserved ejection fraction heart failure, the ejection fraction is greater than 50%, but the left ventricle doesn't fill adequately during diastole, which ultimately reduces cardiac output. Hypertension is the main cause of preserved ejection fraction heart failure. Most likely, this is due to the increased ventricular wall tension and hypertrophy associated with the heart needing to pump so hard against the increased peripheral vascular resistance. Now, the second way heart failure can be classified is by which ventricle, left or right, is affected. With left-sided heart failure, just think what the left ventricle does. It pumps blood to the rest of the body. If it's failing, there's going to be a decrease in cardiac output and peripheral blood flow. Where will the blood back up? Think about the normal flow of blood through the heart. It flows from the pulmonary circulation to the left atrium to the left ventricle. So ultimately, it backs up into the lungs. Now, when the right side of the heart fails, blood backs up into the systemic venous system, since blood flows normally from the vena cava into the right atrium and then the right ventricle. Let's look closer at the clinical manifestations. I do love this diagram because it really details for you what the manifestations are depending upon on which side is affected. So again, with the left ventricle, as I mentioned, decreased cardiac output. So you're going to have those signs of decreased tissue perfusion. With the pulmonary congestion, there's going to be impaired gas exchange, so they may have cyanosis, so, blue fingertips or even sometimes around the mouth, signs of hypoxia, and pulmonary edema, fluid back up into the lungs. So orthopnea is when the patient becomes short of breath when they're lying flat, and many patients who have chronic left-sided heart failure sleep in a recliner with their head elevated. Paroxysmal nocturnal dyspnea is when they become short of breath suddenly at night, and that could be due to the increased amount of fluid that is circulating when they're in a recumbent position. And also, too, they can experience cough with frothy sputum, and that occurs in pulmonary edema, and we're going to look closer at that on the next slide. Now, looking at right ventricular heart failure, the manifestations are all due to congestion in the peripheral tissue. Dependent edema and ascites, which is fluid in the peritoneal cavity. Liver can become congested, and GI tract becomes congested, so they have anorexia or poor appetite, some GI distress, and weight loss because they just don't feel like eating. I want to spend some time talking about acute heart failure syndrome. It is the gradual or rapid change in heart failure signs and symptoms resulting in need for urgent therapy. It is a result of severe pulmonary edema, which we talked briefly about on the previous slide related to left-sided heart failure. Acute pulmonary edema is the most dramatic symptom of acute heart failure syndrome. And, as I reflect back on when I was working in a cardiac step-down unit, there were several times that I was caring for patients who'd had a myocardial infarction and experienced severe pulmonary edema. And this was the type of patient that we did send to the intensive care unit. Sometimes quite often they needed to be on a ventilator. So I just want to talk a little bit about that image so it makes hopefully more sense to you. The top diagram shows the normal exchange of fluid in the pulmonary capillaries, and hopefully you can see the alveoli at the top. The image right below is showing you what is happening at the capillary level. So blood from the venous side, as noted by the blue, has a colloidal osmotic pressure of 25 millimeters of mercury, which is what pulls fluid into the capillary. And the capillary filtration pressure on the arterial side, as noted by pink, is what pushes fluid out. And it's 10 millimeters of mercury here. So together, both of these pressures keep blood in the capillaries, which is where you want most of the blood to be. But with pulmonary edema, while the capillary colloidal osmotic pressure is still at 25 millimeters of mercury, the capillary filtration pressure is greater than 25 millimeters of mercury, causing seepage of blood into the lungs. Now, I recognize that the pressures can be confusing, so if you need a refresher, go back to the capillary interstitial fluid exchange section in your fluid and electrolyte chapter. And if you can't access the link in this presentation, it's in the learning module. I believe it's a Khan Academy, and it's really, really good. So looking at the manifestations there that are listed on your slide, I think most of them will make sense to you. The last one, pink frothy sputum, which is caused by air in the capillary, in the alveoli, mixing with the serum albumin, and that's what causes it to be kind of this pink frothy sputum. And this is, you see it because the patient coughs it out. Now we are shifting gears to circulatory shock. Circulatory shock is an acute failure of the circulatory systems to supply the peripheral tissues and organs with an adequate blood supply, which results in cellular hypoxia. I want to talk about two primary compensatory mechanisms that are present in all types of shock. The sympathetic nervous system responds to decreased blood supply by increasing the heart rate, constricting the blood vessels. The heart muscle increases its force of contraction, and the bronchioles relax or open up more. And I think you could see how these mechanisms would increase oxygenation. And secondly, renin is released. Hopefully you remember that renin leads to an increase in angiotensin II, which causes vasoconstriction and aldosterone secretion. And what does aldosterone do? Right, it causes water and sodium reabsorption, which increases volume in the blood vessel. Now, these compensatory mechanisms cannot be sustained over the long term, and they reach a point where they become detrimental. There are 4 types of shock, and the diagram on the page shows the compensatory mechanism for hypovolemic shock, which we will look at first. Hypovolemic shock is an acute loss of 15% or more of circulating blood volume, hemorrhage, or shift of blood out of the vessels into the interstitium. Look at the diagram, particularly the image on the lower left. The dashed line represents decreased blood volume in both the arterial and venous systems. Manifestations include tachycardia, increased contractility, vasoconstriction, which, as I mentioned earlier, was compensatory. Actually, all of those are. Thirst, increased heart rate, cool, clammy skin, decreased blood pressure, decreased urinary output. And I should mention that thirst and tachycardia and peripheral vasoconstriction are early signs. And as the shock worsens, blood pressure drops and respiratory rate becomes more rapid. If you do best with visuals, click back on the previous slide that shows the compensatory mechanisms of hypovolemic shock. The manifestations reflect the clinical the mechanisms reflect the clinical manifestations. With cardiogenic shock, the heart doesn't pump effectively to move blood forward to the rest of the body. Look at the second image on the bottom of the diagram. Notice the red X. That is showing where blood flow is impeded. It's called cardiogenic. So you can just break the word down and know that means it starts in the heart. The most common cause is myocardial infarction. The patients experience cyanotic lips, nail beds, and skin, and a narrow pulse pressure. Just a reminder, a narrow pulse pressure is when the systolic blood pressure is low, but the diastolic blood pressure is normal or high. An example would be like 80/70. In obstructive shock, there is a mechanical obstruction of flow of blood through the central circulation, such as in the aorta, heart, and lungs. See the third image on the bottom. Notice the red X's that are showing possible sites of blockage. Obstructive shock can be due to cardiac tamponade, a pneumothorax, which is air in the pleural space, but the most common cause is pulmonary embolism. The main manifestations of obstructive shock are due to elevated right heart pressure and failure, such as increased jugular venous distension. Now, distributive shock is a loss of vasomotor tone, enlargement of the peripheral vascular compartment, and displacement of the vascular volume away from the heart and central circulation. There are three types: neurogenic, anaphylactic, and septic, and they're all due to massive vasodilation. With neurogenic, that is caused by a decreased sympathetic control of the blood vessel tone. It can occur in spinal cord injury, brain injury, or even fainting due to emotional stress as a form of a neurogenic shock. The manifestations with this shock differ from the others. The heart rate is slow and the skin is warm and dry. Anaphylactic is the most severe systemic allergic reaction in which histamine release causes major vessel dilation. These patients experience vasodilation and increased capillary permeability, which lowers blood pressure. They experience abdominal cramps, apprehension, warm burning skin, itching, hives, respiratory distress, wheezing, coughing. You may know someone who carries an EpiPen, and the epinephrine in the EpiPen is to reverse the symptoms of anaphylaxis by causing vasoconstriction and bronchodilation. It can be life-saving in cases of anaphylactic shock. And the last type of distributive shock to discuss is septic shock. And I want to mention it is the most common type, and it is a systemic immune response to a severe infection, causing hypotension, warm flushed skin, and changes in cognition. And briefly, I just want to mention the complications associated with shock so that you can note that it does affect many body systems. Acute lung injury or acute respiratory distress syndrome, and I have the mechanism listed there for you, can cause acute kidney disease, gastrointestinal complications, disseminated intravascular coagulation, and multiple organ dysfunction syndrome. So what do you know? Time to test your knowledge. The characteristic pink sputum produced in pulmonary edema is tinged with blood. True or false? It is true. In pulmonary edema, the alveolar capillary membrane is damaged and blood from the capillaries moves until the alveoli. The blood from the capillaries causes the sputum produced from the lower respiratory tract to appear pink or light red. An ejection fraction is represented by preload divided by stroke volume equals ejection fraction. And that is false. It's actually stroke volume divided by preload. So you want to take the stroke volume, the amount that's ejected with each heartbeat, and divide it by the amount of blood that's in the ventricle at the very end of diastole. Okay, we have a case here. Mr. T has heart failure, complains of severe shortness of air with any activity, and waking up during the night several times to urinate. He says he feels weak, dizzy, and anxious all the time. His wife tells you he is forgetful. You notice his lips are slightly blue in color. What is causing these manifestations? So I suggest you pause this presentation and just make a note, write out what the manifestations are, and see if you can figure out what is causing them. And which side of the heart do you think is failing? So We'll just look at each of these manifestations one by one. Dyspnea with activity is due to decreased cardiac output. So there's not enough oxygen circulating in the body. And actually, blood is possibly backing up in the lungs, and that's causing the shortness of breath. Urinating at night is nocturia, Nocturia, and that occurs when a patient is supine. There is increased renal blood flow, causing increased urine production. The weakness, dizziness, anxiety, impaired cognition are all due to decreased cardiac output. Cyanosis, due to decreased oxygenation. And what side? I would say the left because of the multiple respiratory-related manifestations. There's no edema, no mention of edema in the feet or ankles or jugular venous distensions or ascites, which would lead me to right-sided heart failure. What type of shock is caused by low blood volume? I'll give you a hint. If you just break the name down, you can figure it out. Yes, hypo means low and volemia means blood volume. And this can occur due to trauma, surgery, or third space fluid loss. Another case, Mr. M was injured in a motorcycle. On arrival to the hospital, he's presented with bleeding from the right leg, restlessness, pallor, sweating, elevated heart rate, weak pulse, rapid breathing, lack of bowel sounds, and blood pressure was slightly elevated. What do you think has happened to this patient's stroke volume? Well, it's decreased. That's why we're seeing those manifestations. Cardiac output, it's decreased. And remember, stroke volume is the amount of blood ejected with each heartbeat, and cardiac output is the amount of blood ejected in 1 minute. So if the stroke volume is decreased, the cardiac output is decreased. And the sympathetic nervous system, that has definitely been stimulated as a result of the decreased cardiac output. That's why the heart rate has increased, the breathing rate has increased, blood pressure slightly elevated. Which type of shock is the result of a severe allergic reaction? Anaphylactic shock is caused when inflammatory mediators are released, and the mediators include histamine, acetylcholine, kinins, leukotrienes, and prostaglandins, all of which cause vasodilation. The volume of blood that stretches the ventricle at the end of diastole refers to preload. The volume of blood that stretches the ventricle at the end of diastole is also called end diastolic volume. Congratulations, you have completed heart failure and circulatory shock, and actually all of cardiovascular for that matter. I hope you will take time for self-care. I'd like for you to go to YouTube and enjoy nature's beauty, and it's only 10 minutes. It's really worth it. If you're unable to click the link in this video format, just go to the TED Talks and search for Nature, Beauty, Gratitude. Thank you.